Okay, well, good morning, everyone. We're going to go ahead and get started. First, I want to welcome everyone to the PHRA February webinar over Health Rosetta. We are going to, let me go ahead and do a couple of things here. I'll start my video screen. It's a cold day outside, so as you guys can see, I'm at my house today, launching from the house. And before we get started, I wanted to take a quick second to just welcome everybody and thank Jessica Howell in particular and PHRA for inviting me to share a little bit today about the Health Rosetta. I really appreciate it, and I'll try real hard not to make you guys regret it. But I'm really excited to initiate this conversation today. And I say initiate because hopefully today's conversation will either inspire you to initiate these conversations or at least continue having them around high performance healthcare benefits in our companies, in our communities, and in our government entities. And I want to first direct your attention, if everybody can see the motto down there that's underneath the PHRA logo, it says down there at the bottom, providing connection and involvement in our community. And guys, I love this because today that's what we're going to talk about. And we're going to talk about putting that into action, connecting and getting involved at the community level on some of these initiatives. Well, guys, we face some very major challenges, some really large challenges in healthcare. And I don't think anybody that's attending today is going to argue that point. There's a lot of challenges that we face in the healthcare systems. And those challenges are affecting employers directly as well. But I believe that it's employers who sponsor health benefits plans. They stand in a very unique position to bring about the necessary changes that are so desperately needed. After all, it's employers and their employees who are the true payers of healthcare in this country. And today, 70% of people gain access to our healthcare system through an employer-sponsored health plan. That means that the plans that we're sponsoring as employers and the plans that we're offering our employees, they have a direct and a profound impact on people's health, on their financial well-being, and on their actual behavior as healthcare consumers. So guys, today I'm here to challenge you a little bit. I'm going to challenge some status quo mindsets and beliefs that are out there. And I might even say some things that make you feel a little bit uncomfortable. But, I think that that's okay, because if we're not all feeling a little bit of discomfort around the status quo healthcare and benefit systems, well, then we really need to kind of reevaluate that. So not only are we going to talk quite a bit about what's wrong in our healthcare system and what's wrong in employee benefits, but we're also going to spend some time talking about what brave employers from around the country are doing to fight back. We're going to discuss a blueprint, so to speak, that employers are following to reduce their healthcare and benefits costs while simultaneously improving their plans, improving access to care, and actually improving clinical outcomes for their employees. And the good news is it's working. My name is Josh Butler, and I'm the president of Butler Benefits and Consulting here in Amarillo. Butler Benefits is a boutique healthcare consulting and brokerage firm that my wife, Allison, and I launched almost 6 years ago. And in 2018, I was accepted into the initial cohort for the Health Rosetta as an accredited healthcare advisor, along with 66 other advisors from around the country. And today, the ecosystem has grown to almost 200 accredited advisors around the country, along with numerous notable collaborators such as Bill Gates, Marty McCary, who is a Johns Hopkins surgeon and New York Times bestselling author, and Tom Emmerich, who ran corporate benefits for companies like Walmart, British Petroleum, and Burger King. And the Health Rosetta's mission is really simple, and it's summarized in a very short mission statement right here. Healthcare has already been fixed. The mission is to scale the adoption of those fixes. Now, that's a pretty bold statement. And the question is healthcare already fixed? Well, today we're going to talk more specifically about why I believe it is, why the Health Rosetta believes it is, and why a growing number of employers around the country are starting to believe it too. So let's dig in. Dave Chase is the founder of the Health Rosetta, and he likes to begin many of his talks and his presentations with the statement that healthcare stole the American dream. And in so many ways, he's right, especially financially. It's a massive issue in our society, and it's wreaking havoc everywhere we look. Healthcare costs are extrapolating crucial resources from local and state budgets. It is literally driving millions of Americans to financial bankruptcy, and there seems to be no end in sight to the rapidly increasing prices. And to add insult to injury, our society isn't getting any healthier for it either. Despite the amount of money that we spend collectively as a nation on healthcare, millions of Americans are still left either uninsured or they're unable to afford even basic healthcare. But it doesn't have to be this way. Historically, we as Americans have been we've been exceptional problem solvers, right? It's what we do. From civil rights to energy independence, problem solving is something that generally speaking, that we're very good at as a society. And when you think about all the amazing discoveries and breakthroughs that we have achieved and all of the complex problems that we've been able to solve as a society, you'll quickly realize that very few of those discoveries and breakthroughs were the result of a single person. In fact, almost all of our historical breakthroughs and discoveries were the result of close collaborations between small groups of people. Now, I love this Albert Einstein quote right here because change and progress, they always require us to think in a new way. And that's what the Health Rosetta represents in healthcare, a new way of thinking and a new way of working. Another favorite quote of mine as it relates to this topic is from famous American anthropologist Margaret Mead, who once said that never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. For instance, and speaking of Albert Einstein, did you guys know that he closely collaborated with two of his fellow students at ETH Zurich, Marcel Grossman, who you see here on the left, and Michel Besso, who you see up there in the top middle. Now, discussions among these three men greatly helped and influenced Einstein, and it helped him derive his special theory of relativity that he is now famous for and best known for. But Grossman, he was also a very talented mathematician in his own right. And his personal notes greatly influenced and helped Albert Einstein. In fact, the Einstein-Grossman theory, published in 1913, was a precursor version to the final theory of general relativity. And very frequently, Albert Einstein praised these two men, and he frequently stated that he would not have been able to achieve as much as he did without their insight and collaboration. Here's another famous collaboration that we all know very well. But when John Lennon and Paul McCartney first started writing and recording songs together as part of the Beatles, they had no idea how far their partnership would take them. Now, while the band as a whole still lives on as one of the most influential in history, this dynamic and creative partnership that Lennon and McCartney embodied was the driving force behind the sound that changed pop music forever. And this collaboration here may not be quite as important or as inventions or theories, but I can promise you it tastes better. This is Ben Cohen and Jerry Greenfield. Now, they did the world a favor by setting the bar very high for interesting and unique ice cream flavors. Together, they've made the world a better place with chunks of fudge brownie and chocolate chip cookie dough. The two men have very different strengths when it comes to business and creativity, but together, they created one of America's most beloved and admired brands of ice cream. Now, all of us recognize the end products of these famous collaborations, right? And we all certainly can appreciate the work and the determination and the risk and the decisions that went into each of these. So when people ask me, Josh, what is the Health Rosetta exactly? Okay. The shortest and best description that I can give you is that it's a collaboration, okay? It's a collaboration of the country's brightest minds, best innovators, and problem solvers in the realm of healthcare, risk management, and employee benefits. Now, here we see a stack of components that the Health Rosetta focuses the collaborative efforts on scaling. The actual active collaboration is taking these best-in-class solutions and strategies, not theories, okay, but actual solutions and strategies that other organizations and companies have already implemented, and then successfully scaling those solutions across the country through other businesses and other communities. Now, we're going to come back to some of these components a little bit later. But in addition to scaling proven solutions, the Health Rosetta serves as a massive think tank, so to speak, for innovation. And let me tell you guys, the value that this generates is enormous, and it's amazing to watch. When you get doctors and nurses and hospital administrators, employers, HR professionals, attorneys, and a whole host of other invested entities, you get all those people together to collaborate with one another to solve healthcare's greatest challenges. It's very amazing and it's very impactful. So the Health Rosetta is literally leveraging the uniqueness of our people and the uniqueness of the American society, collaborative problem solving. So throughout the conversation today, you guys are going to notice that I really like to use quotes. And so I'm going to use a few today. And here's another one, again, from Albert Einstein. He also said once that if he had an hour to solve a problem, that he'd spend 55 minutes thinking about the problem and 5 minutes on the solution. Now that makes sense, right? I mean, we understand this because the better we understand the problems that we're trying to solve, the easier they are to solve. That's just common sense. And that's what Einstein was saying. And healthcare's biggest problems are pretty obvious, especially to the people on the webinar today. This comes as no news. It's expensive. It's hard to navigate. It's hard to understand. Many people don't have easy access to care, et cetera, et cetera. But how well do we really understand these issues? How well do we really understand what's causing these problems? Better yet, how well do we really understand what's allowing them to repeat over and over and over again year after year? So today we're going to spend a little bit of time analyzing some of the major problems. Here's one right here. In 2018, the United States spent $3.6 trillion on healthcare in 1 year. $3.6 trillion. Now, guys, just for a second, just contemplate this figure for a moment. It's an astronomical number, and it's 20% of our entire GDP, and that number is growing every year. For a little bit more perspective on that figure, you can see here that what we spend on healthcare in 1 year is more than the entire economies of Brazil, the United Kingdom, Mexico, Spain, and Canada, just to name a few. Now, this is causing more harm than we actually know. Multiple studies indicate that as much as 30% of this spending is deemed wasteful every year. Waste in the form of a failure of care delivery, failure of care coordination, over-treatment or low-value care, pricing failure, fraud and abuse, or administrative complexity. Now, out of each of these examples of waste, that last one, administrative complexity, accounts for the single largest amount of waste every year at $270 billion. That's $270 billion a year that gets wasted just because our healthcare system is administratively more complex than it should be. Now, everybody, y'all know this. Our healthcare system is very complex, right? But I contend that our healthcare system didn't get this way by chance. However, I feel like it was purposely designed to be this way. It was purposely designed to be this complex so that certain players in healthcare can continue on in the status quo mechanisms that are draining resources from private companies, public budgets, and employee paychecks. This fact translates into a 40-year wage stagnation experienced by the working class in this country. Rapidly increasing healthcare and benefit costs have eaten virtually all income gains made by the middle class over the last 40 years. And I can't help but think, guys, that this issue right here is playing a major role in much of the societal unrest that we're witnessing today. Because year over year, the ability to afford quality healthcare and insurance is a top concern of working families. Now, here you see that trend indexed for inflation over that 40-year period. But you can also see through this chart right here that employers are not being stingy with their money either. In fact, you can see here that employers year over year have consistently increased their contributions towards real compensation per hour per employee consistently over this time. But something is eating away at our livelihoods. And primarily, it's healthcare. Being deemed the chart of the century in our industry, here you can see how household costs such as food, housing, clothing, cars, many things. They've all either become more affordable or the price of those things have risen slower than wages over this time period. But take a look at healthcare related prices. They have simply exploded over the last 20 years, far outpacing middle class wage gains and the consumer price index. The only other thing that comes close to this type of hyper price inflation, you can see it there, is a college education. And I'm sure many of you are experiencing that right now. I know a college education is much more expensive today than when I graduated, and I'm not that old, guys. But this dramatic rise in healthcare costs, it directly affects health insurance rates too. So here's one thing to keep in mind. Health insurance is expensive and contorted because our health care is expensive and contorted, not the other way around. Health insurance rates follow these same trajectories. And in an attempt to rein in health insurance premiums, many employers have merely shifted healthcare costs onto their employees through higher deductibles, higher copays, and higher premiums. But the question is, are those strategies working? Have they worked? Is shifting more and more cost to employees actually lowering the unit cost of care? It's not. And there are reasons why that we're going to discuss in a moment. This chart here is an illustration of what I was just talking about, the cost shifting that I just mentioned. Since 2005, employee spending on deductibles alone has risen more than 230%, while overall wages have remained fairly flat over that same time. Now, the impact of that is far-reaching. According to a 2018 poll from Amino, less than a quarter of Americans, less than 25% of Americans state that they could cover an unexpected medical bill of $2,000 or more. And in 2006, only 1 in 12 insured persons in this country had an annual deductible more than $1,000. But today, over half of the insured people in this country have a deductible north of $1,000. So this quick cost shift over to employees is a leading factor in why healthcare has become the leading cause of personal bankruptcy in this country. Now, I know that you all knew that. You knew that healthcare was the leading cause of personal bankruptcy in America. But did you know that 75% of the people who filed a medical bankruptcy had health insurance at the time? And yet another study illustrates that between the years of 2012 and 2019, patient balances after insurance paid out grew by more than 60%. The crippling financial impact this has on individuals and households is obvious, but it's also had a major impact on hospitals, doctors, and other healthcare providers. Sage Growth Partners released the results of a survey of 100 hospital CEOs in June of 2018. Out of those CEOs, 36% said that their hospital faced more than $10 million of bad debt, and 6% reported bad debt over $50 million. Now, what's bad debt? Part of that bad debt, a big chunk of it, is uncollected patient deductibles and co-insurance. That's considered bad debt. So out of those respondents, 59% then cited insurance reform as the primary cause of bad debt growth. That includes the associated increases in copays and deductibles. So needless to say, these challenges are not just affecting employers and their employees. Healthcare issues they're affecting entire communities, whole communities. So what's being done about these specific problems at the employer level, or what could be done? One of the first things that employers who sponsor health plans should really understand and embrace is this right here. You run a healthcare business whether you want to or not. Now, the reason we say that is think back 30 years ago. Employee benefits might have been what? Number 30 on the P&L. It might have been the number 30 line item on the P&L, maybe. Well, not anymore, okay? In the clients and prospects that we work with, we consistently see healthcare and employee benefits in the top 5 highest expenses on the P&L. Sometimes it's as high as number 2, right behind payroll. As an example, our local city government here spends around $23 million a year just on employee benefits. That's one of the single largest budget items that our city government has. But guys, that's a $23 million business unit. And Warren Buffett agrees. Not too long ago, he said this about General Motors, because GM spends more on employee benefits every year than they do on steel to make their cars. Starbucks spends more money every year on employee benefits than they do on coffee beans. Now, I make this point because employee benefits is no longer just a human resources function and responsibility. It's a business unit that requires strict financial oversight and management, like other financial sectors of a business. And for that reason right there, we are interacting far more frequently with controllers and accountants and CFOs, even CEOs, in their purchasing processes, right along with their HR professionals. But you know, there are many employers and healthcare professionals around the country that are implementing effective solutions, and they're working to reform much of what is broken in our healthcare system. And thankfully, that number is growing by the day. But there are still several fundamental obstacles that employers face that make it much more difficult for them to adopt change. You can call it competing interests, you can call it misaligned incentives, doesn't really matter. The point is that there are certain players in healthcare that benefit far more greatly from the status quo than if things changed. So we need to address a few of those, and we're going to talk about those really quickly. We're going to call these competing interests to your health plan. Number one, your broker. Hey, wait a second, guys. That's me. How am I a competing interest to a health plan, right? Well, in early 2019, I contributed to an article by Marshall Allen. Marshall is a Pulitzer-nominated investigative journalist in healthcare, and he writes for a publication called ProPublica. And if you just Google ProPublica and Google my name together, you can find this article and you can read all about it. But for this piece, Marshall did a lengthy investigation into broker bonuses, commissions, and other forms of compensation and financial gifts that insurance companies use to sway brokers into selling their products, even when it's clearly not in the best interest of the client. Now, this article, as you can imagine, it ruffled a few feathers, but what it did is it started to expose the misaligned and the often undisclosed incentives that brokers are offered by health insurance companies. So let me first start with commissions, because they're a little bit different than what we're going to talk about next. But fundamentally speaking, commissions are a form of compensation that are tied to insurance premiums as a percentage of the total monthly premium, right? And it typically ranges anywhere from 4 to 7%. That's a good average. Now, if a broker gets paid a commission, it doesn't mean that the broker's a bad person or that they're doing something nefarious or that it's a bad practice in general. After all, I mean, you guys expect your brokers to get paid somehow, right? Well, yeah, of course. But what you cannot argue is this, is that broker commissions go up as health insurance premiums go up, not down, okay? So when you get a 15% renewal increase on your plan, just understand the broker is getting a 15% raise at the same time. So fundamentally, just fundamentally speaking, brokers who are paid by commissions are rewarded financially as your costs go up, not down. That's not necessarily always the broker's decision or their fault, but it is a fundamental misaligned incentive that exists in my industry. Now, the Health Rosetta stance on commissions and commission-based brokers is very, very simple. Just be fully transparent with your client and disclose all forms of revenue and incentive. Let your clients see what you're getting paid as a broker. Now, we do this because employers deserve to know whether or not their brokers are being offered financial incentives to place your business in a specific place or with a specific carrier. And you deserve to know what your broker or advisor is making. Now, aside from commissions though, there are other financial methods that carriers and vendors deploy to sway brokers to sell their products that are a little bit more controversial. Things like commission overrides, retention and new business bonuses, bonuses to move companies from self-funding, which is less profitable for a carrier, to fully insured plans, which are far more profitable for carriers, luxurious vacations, even chances to face Hall of Fame pitchers like Mariano Rivera. How about a luxury stay in Bora Bora, or a chance to earn up to a $50,000 cash bonus per eligible case, which is a specific new group bonus being offered by one carrier just last year. Now, these types of financial incentives are literally illegal in the financial sector. And, you know, if your financial advisor was receiving kickbacks like that, they could get in a lot of trouble and possibly even face prison, okay? The healthcare pork barrel is full of incentives to sell for specific carriers. A close colleague of mine who he used to work at a large brokerage firm up in the Northeast said that his old firm's bonus, okay, not his personal bonus, but the firm's bonus with one carrier reached into the 7 digits if the firm retained 98% of the existing business with that particular carrier year over year. Ladies and gentlemen, that's called a retention or a persistency bonus, and they can get very, very large. In addition, these types of bonuses are commonly offered to brokers with what are called no-shop clauses, okay? That's an agreement that the broker will not solicit competitive bids on behalf of that employer for a year, or it may be some other specified period of time. But what if staying with that particular carrier isn't what's in the best interest of the employer? Now, just for a moment, I want everybody to stop and ask yourself a question. Is it possible, just possible, and I'm not saying your broker or anyone's broker is accepting things like this or not. I have no idea about any one specific broker on this webinar, but just generally speaking, do you think that a 7-figure persistency bonus could potentially influence a broker's recommendations to their clients? Of course they could. If things like this didn't work, the carriers wouldn't offer them. So it's a completely fair question for employers to be asking. How your broker is being compensated matters. But what matters even more than that is how transparent they are with you around the issue of compensation. Now, I'm going to show you an example of what is expected and required of Health Rosetta advisors a little bit later on. Next, your PPO network. Now, the lack of transparency is arguably the biggest competing interest to your health plan in your company. And we just addressed the lack of transparency in broker compensation. So now let's talk about PPO networks, how they work, and how they're truly not delivering value to your organization, but they serve as a competing interest against most employers' interest by elevating the unit cost of care. PPO stands for Preferred Provider Organization, and in theory, they're supposed to lower healthcare costs, but in reality, are they? I don't think they are. That's because insurance carriers are in the business of selling you discounts through their networks. It's how they show their value to employers. Look how much money we just saved you. What would you do without this discount? Look how much you would have paid without this discount. So they're more interested in providing a deeper discount versus actually lowering the unit cost of care. So let's analyze the PPO discount shell game that gets played through networks. So, okay, guys, here's my car and I'm putting it up for sale. Just kidding. This isn't really my car. Okay, but take a look. It's a 2020 Ferrari Omologata, 6.5 liter V12 that pumps out 789 horsepower of torque. It is a beautiful car. Look at this thing. It's an amazing car, right? And guys, I'm offering to sell you this car at a 90% discount. I'm gonna give you a 90% off. That is an amazing deal right there, right? Anybody interested in this deal? 90% off? Well, hold on just a second. You know, because what I failed to tell you is that my asking price for the car is $100 million, okay? So now who's interested? Even at 90% off, do you think it's a good deal? It's not, right? And I'll tell you guys what, I'll sell you anything I own for a 90% discount under one condition. So long as I get to set the starting price. And guys, this is precisely what happens in healthcare. Think about it. Healthcare is the only thing that we purchase in our economy before we know the price or the quality of what we're buying. I can't think of anything else we purchase under those circumstances. Imagine going into a steakhouse, okay, and you sit down, you're hungry, it's been a long day. Waiter comes over to take your order, but you notice that there's no prices listed on the menu. So you ask your waiter, hey man, how much for the ribeye? Oh, sir, we can't give you a price up front. Well, why not? Well, we have to see what kind of credit card you pay with before we know what to charge you. I'm sorry, do what? What does the price of your steak have to do with what kind of credit card I have? Nothing, right? But you're starving and it's been a long day, like I said, and you need to eat. So you go ahead and you order the ribeye anyways. 60 days later, you get a bill in the mail for 10,000 bucks. Why? Because the sous chef in the kitchen didn't take American Express, right? Now, when you frame it like that, it's kind of ridiculous when you think of it in this analogy, right? But this is precisely how healthcare is being consumed and purchased through networks. Here's an example of how that plays out at the hospital level. This is an illustration from a data analytics tool that we use for our clients. And this tool allows us to analyze DRG and CPT codes at every hospital in America. Now, DRG and CPT codes are just procedure codes, okay? And for this example, we're going to use a procedure code or a DRG code 233, which is a coronary artery bypass surgery. Now, the pinkish bar there represents the hospital's average billed amount, okay, the billed charge on average. The yellow bar represents the self-reported cost for this procedure of the hospital, for that procedure at this particular hospital. And the blue bar is an average of what Medicare reimburses for that procedure. Now, the green line you see in the center there, that is, the green line is a weighted quality score. Sorry, guys. It's a weighted quality score at these particular hospitals. So I picked 2 hospitals that are in the same city. They are in Texas for this example. On the left there, you see this hospital charges $282,000 on average, and the hospital on the right charges $164,000 on average for the exact same procedure. Now, most PPO contracts reimburse either a percentage of or a percentage off the billed charge amount. And the average PPO discount, just on average, is around 50%. So think about this for a second. If both hospitals are covered, they're in your PPO network, it's pretty obvious that your plan is paying a lot more at one facility versus the other for the exact same procedure. Now, most health insurance companies do include both of these hospitals in their PPO networks. So your employees can go to either one of these locations, but it's obvious, it's clear where employees should be incentivized to go. And here's why. Take a look at that green line. Look at the quality metric. The quality of this procedure, of this surgery, is actually scored higher at the lower cost hospital. And we see this inverse correlation in healthcare all the time. Unlike other things like homes, cars, or clothes, high quality healthcare typically costs less than low quality healthcare. But guess what? The networks don't make this type of information readily available to you. In fact, they tell you that it's proprietary information, and most refuse to even share it at all. If your objective as an employer is to provide high quality, high value care to your employees at the best price, which one of these hospitals do you want to see your employees going to for this particular procedure? Yeah, right. The one on the right. I would. So fundamentally, PPO networks are working as a competing interest to your objective, because within the same PPO network, what you find are very high quality, low cost providers, but you also find many low quality, high cost providers. That is a major quality control issue that has a profound impact on the quality of care that your employees are receiving, and it has a profound impact on your organization's bottom line. Now, I'm going to drill down a little bit deeper on this issue right here and talk about why this right here, this issue, is so critically important. So I'm going to use another analogy. After 30 years of wear and tear on that knee, it's finally time for you to get it fixed, right? You've been referred to an orthopedic surgeon, but is he or she a good one? Will my surgery be successful? Will I fully recover? How much is it going to cost me? All these questions are questions that are going through your mind that leading up to this procedure, right? So I borrowed the next 2 slides from a colleague of mine in Georgia who's done a wonderful job here explaining the failure of PPOs in this way. As part of analysis that we did for a Florida-based employer, this is a breakdown of orthopedic surgeons in a 60-mile radius of this employer in Florida, okay? And again, for this example, we're going to use a total knee replacement as the example, okay? Now, based on criteria and data that we have access to and that we use to locate high-quality, low-cost surgeons, 4 surgeons out of 60 met our quality and cost criteria. The top of the funnel identified 60 surgeons who were simply in network, okay? Any 60 of these were in the PPO network and could perform the procedure. The first criteria as we step down that the surgeons had to meet was case volume. How many knee replacements has this surgeon performed in a year? After all, nobody wants to go to an orthopedic surgeon who's only performed two knees a year, right? So we set the threshold for this example at 50 procedures per year. Right away, that culled 46 surgeons out of the funnel right away, leaving only 14 that met that criteria. The next criteria that we evaluated was quality, where we look at things like complication rates, admission and readmission rates, infection rates, mortality rates, and even malpractice issues, okay? And so at that stage, 6 more surgeons were eliminated due to quality issues. Cost was the next criteria, where 2 more surgeons were eliminated due to excessively high costs and prices that they charge for this procedure, also with the excessively high price of the durable medical equipment that they used. It finally narrowed it down to 4 top surgeons in the area that performed the highest volume of cases with the least amount of complications and errors at the best available price. 4 out of 60. But keep in mind, all 60 of these surgeons were in network. Here is the breakdown of the 14 surgeons who met the volume criteria, okay? I want you guys to take a real close look at this. And I want you to see why the lack of transparency into your PPO network providers can actually be very, very dangerous for your employees. Take a look right here. This surgeon right here was the only one that we found that had a mortality in the quality data. And ladies and gentlemen, he didn't just have one. His mortality rate score for this procedure alone was 4.47, and multiple people died under his care while performing this procedure. Now, I got a question. Who wants to go get their knee done by this surgeon right here? I don't think anybody would. In the medical industry, this right here is what is known as a HODAD, hands of death and destruction, okay? But guess what? He's in the PPO network. So who's monitoring things like this for the organization? Because it sure isn't your PPO network. Next, and the last competing interest we'll talk about today are your big insurance carriers of the world. In our industry, we have an acronym for that. That's called the BUCAs. Okay, that's what we call them in our business. That's just simply an acronym that we use to describe the largest insurers in the country: Blue, United, Cigna, Aetna, Humana. BUCA, okay? Well, guys, the BUCA's fiduciary responsibility is first, as publicly traded companies, are first and foremost to their shareholders and to produce shareholder return. And the more you pay out, or that we all pay out in premiums, the more they can return to their shareholders. Now, this fact has actually been codified into federal law through the Affordable Care Act through a provision that you may or may not be familiar with. The MLR provision, or the medical loss ratio provision of the Affordable Care Act. Now, it deserves a little bit of attention here because it is a major misaligned and competing interest to your organization and your health plan. Now, the Affordable Care Act instituted a medical loss ratio, or MLR, that is defined as the amount of premiums that the insurance company pays out in the form of medical claims. Under the ACA, the MLR requires health insurance carriers in the small group market, that's in the market for employers under 50 employees, that they have to spend out at least 80% of the premiums they take in on actual claims, okay? And in the large group market, it's even more. They have to spend at least 85% of the premiums on actual medical claims. That only really leaves a remaining 20 or 15% for administrative overhead, for marketing costs, and yes, profit, okay? Now, the initial purpose of the MLR was to regulate how much money insurance companies were spending on administrative costs like marketing and salaries and things like that, in comparison to how much they were spending on actual medical claims or quality improvements for the policyholders. The ACA also required insurance companies to publicly disclose their budgets to ensure compliance with this provision. If they failed to do so, or if they didn't meet the guidelines, they are fined, okay? As an additional penalty, if they don't meet the MLR guidelines and they don't pay out, 80 to 85% of the premiums back in the form of claims or care, then they have to provide rebates back to the consumers. So guys, in a nutshell, and I could go far, far deeper into the MLR than I'm going to today, but what the ACA did is it cemented into law a provision that directly ties insurance carrier profits to premiums and the actual cost of healthcare. So here's my question. If you were only allowed to keep 20% of premium revenues, and you had and you're a publicly traded company with a fiduciary responsibility to your shareholders, do you want to keep 20% of $1 million, or do you want to keep 20% of $1 billion? I know what my answer is. So the MLR provision directly linked carrier profits to premiums. The higher premiums go, the more profits carriers make. But keep this in mind, okay? Insurance companies can't just arbitrarily raise premiums. They can't. They must get premium increases approved by their state's departments of insurance. In order to justify rate increases, though, what do they have to do? They have to show greater losses. Well, here's where it gets interesting, okay? Now, at this point, you might be thinking, okay, if these states, keep approving these massive rate increases year after year after year after year, we must be consuming a heck of a lot more healthcare than we did several years ago. Nope. This is an illustration published by the Kaiser Family Foundation that shows how healthcare utilization is actually lower today than it was 20 years ago. And you see right there in 2020, that dramatic drop in 2020, that's because we all stayed home to avoid COVID. And it's because all the carriers or the government shut down all elective medical procedures for a little while. So actually, as a country, we're utilizing less healthcare today, not more. Well, if increased utilization isn't what's leading to higher premiums, what's the root cause of the rate increase? What has to happen? It's the price. It's the price of care that's going up. The price of care has to be driven up artificially since consumption isn't increasing. And that's right, ladies and gentlemen. The more the carriers pay out through higher claims and higher prices, the more reason they have to come back to the State Department of Insurance, request premium hikes the following year, okay? And what's happened? Rates have dramatically increased, as you would expect. So when we get asked questions like, well, Josh, how is it even possible that you're able to get us, better healthcare pricing and rates than the large insurance carriers? Now, guys, it's not a matter of ability. It's not a matter of ability. It's not because we possess some secret magic fairy dust. All it is a matter of motive and financial incentive. The BUCAs have little to no incentive to lower your premiums because that, ladies and gentlemen, would cut into their profit. Now, since the passage of the ACA, let's take a look at how the MLR provision has actually impacted the BUCAs. Did it work? Did the MLR, cut into their profits? Did it limit their profits? Here's the stock performance of the 5 largest insurance companies in America, okay? They've done pretty well, I would say. And here you see around 2010, that's the passage of Obamacare. And you can see the performance of their stuff. You got stock in the major health insurance companies, congratulations. I bet you're grinning because they've done very, very well. Yet I want you to remember who's footing this bill, right? We are employers and employees who are sponsoring health plans and paying premiums, or self-funded employers who are actually directly paying for healthcare. Even in the midst of a global pandemic, carriers are posting record profits nearly every single quarter. So if carrier profits are tied to premiums, how much incentive is there for them to lower your premiums? We need to understand these challenges that we face because it's the first step in overcoming them. So for a second, let's go back to what Einstein said earlier. In order to change the world that we've created, and we've no doubt created the status quo world that we've been living in, we must change our thinking. We have to, and when we change our thinking, we change our actions. And when we change our actions, we change our outcomes. Dave Chase would be the first person to tell you that the solutions we're about to discuss next that are promoted by Health Rosetta, they don't require a tremendous amount of intellect. They don't require you to be some kind of genius, okay? In fact, Dave says that courage and will are the 2 main things that we need to implement change because the solutions themselves are practical and they're commonsensical. So employers who are mustering the courage and willingness to begin transitioning their plans to high performance health plans are making a significant difference in their organizations, in the lives of their employees, and in the communities at large. They're solving many of these problems by reducing their expenses anywhere from 20 to 50%, and then reinvesting those dividends back into their employees, back into their companies, and back into their communities. Now, these are the foundational components of a high performance plan that I showed you a little bit earlier. These are the components that the Health Rosetta promotes. Each of these components play a very pivotal role, but it's important for you to understand one thing. Employers don't have to adopt 100% of these components all at the same time or all at once. Most employers phase these components in over a period of time, maybe 3 to 5 years. Some employers never implement all of the components and are satisfied with implementing just a few of them. Our approach is to meet employers and organizations where they are and just simply agree with one another to work together towards improvement at their pace, step by step. So I'm going to talk about a few of these. For time purposes, I'm not going to talk about all of them, but I have picked a couple that I think are the most important. The first is value-based primary care. Let me tell you what that is. Value-based primary care is the foundational component of a high-performance health plan, okay? 85% of a person's medical needs can be fulfilled by a primary care physician. Yet almost a third of this country reports they don't even have a primary care physician. And that number grows every single year. Value-based primary care focuses more on outcomes, clinical outcomes, than it does on the volume of services that are being performed. Under our traditional insurance model, it's called fee for service, okay? Where doctors are paid for the actual volume of services they provide the patient, not the outcome. But greater volume doesn't equate to higher quality. In fact, many studies illustrate the exact opposite. But by focusing on value-based care, doctors are paid for their outcomes, not volume. This dramatically improves the patient experience, it lowers costs, and it removes incentives to overtreat patients. This model also allows physicians the needed time to properly diagnose and treat their patients because they're not having to rush through patients and trying to bill for as many services as possible. This leads to lower emergency room and urgent care visits, lower hospital admission rates, lower hospital readmission rates, fewer medical errors, and better prescription drug adherence. Value-based primary care physicians become the patient's quarterback, so to speak, navigating them through this very complex and opaque healthcare system. Now, value-based physicians also, they work in conjunction with the high-performance plan, helping ensure that your employees get the right care at the right provider, at the right time, at the right price. Now, think back to my example a few minutes ago about the knee surgery, okay? It would have been nice if your employee had, a value-based physician, not some insurance guy that was helping guide them to those 4 top quality orthopedic surgeons in their network. Last year, Milliman published their highly anticipated 4-year study on direct primary care, or DPC, which is an example of value-based primary care. Now, it included an employer that has 1,000 employees who had implemented DPC, and roughly half of the employees opted into the value-based primary care plan. So keep this in mind. When I tell you about these results were achieved with only half of the company participating in value-based primary care. Here you see, though, 52% reduction in ER visits, 23% reduction in ambulance services, 15% reduction in specialist visits, 20% reduction in hospital admissions. These are all very significant improvements, okay? And they tell me 2 things. Number 1, the actual quality of care and the patient experience dramatically improved for these employees. Number 2, and assuming this employer, they had 1,000 lives, I'm assuming they were self-funded, they probably saved a significant amount of money. Now, I have a client here in the Texas Panhandle that incorporated direct primary care into their plan almost 4 years ago. And together, we've been able to successfully manage claims and do it efficiently enough that their company on their group health plan, they've received a rate pass. That's a 0% increase for 3 consecutive years. And one of the main reasons is DPC. In conjunction with a value-based primary care physician, we're able to better manage those claims and manage those chronic conditions so much more efficiently. So when you invest in better quality primary care, the need for downstream, more expensive specialty care is dramatically reduced. The next one, okay, earlier we talked about the misaligned incentives that have the potential to sway decisions and recommendations of even the most professional brokerage firms. Now, as a requirement, the Health Rosetta requires, as a condition of becoming a broker or advisor in the ecosystem, that the broker or advisor discloses any and all forms of compensation to their clients at least one time per year in writing. This does include things like commissions, fees, overrides, bonuses, vacations, in all forms of compensation and incentives. You have a right as an employer to expect transparency, including disclosures of all conflicts in financial dealings between you, your broker or consultant, carriers, and vendors. Complete and meaningful disclosure of financial and non-financial incentives is the foundation for wise purchasing decisions. Now, the Rosetta includes transparent advisor relationships because getting on the road to building a high-performance plan starts with properly aligning your incentives with your broker or your consultant. Benefits concierge services. Man, I like this one. This one we use quite a bit, okay? I'm gonna tell another story real quick. A few years ago, I think it was in 2018, I get a call from an employee at one of our clients, and he had an umbilical hernia and he needed to have surgery, right? Now, his primary care physician, who he went to see, referred him to a hospital where he was quoted a price. He was smart enough and learned enough to ask for a price before. He was quoted a price of $14,600, and that was just for the facility fee. That did not include fees for the surgeon or the anesthesiologist, just facility. But we had implemented a concierge program, a service program through his self-funded employer to seek a second opinion. So when he called me, I directed the employee over to this program, and he was educated on an alternative option, which was to have his procedure conducted, his surgery done at a surgery center where Butler Benefits holds a direct agreement, okay? Now the surgery center offered us this procedure for $3,500, bundled. And when I say bundled, that means it was the facility plus the surgeon plus the anesthesiologist for $3,500. Now this saved over $11,000 on a single procedure. But here's the great part, okay? Because we helped this employer, he was self-funded, because we helped them save so much money on this one surgery, the employer decided to waive the employee's deductible and their out-of-pocket costs entirely. The employee paid nothing, and the plan still saved a significant amount of money. Now, think about the value that this generates for the employee. Now, this gentleman got a top-notch surgery at a state-of-the-art surgery center, and he paid nothing. So when other employers are raising deductibles to offset costs, employers who deploy high performance and proactive solutions are finding ways to eliminate them for employees, not raise the deductible, find a way to eliminate it. High performance plans don't just ask employees to be wise consumers of care, they provide services and solutions that employees can easily access. Wow, pharmacy benefits. Man, if you think health insurance or MLR provisions are complicated, let me tell you something. They don't hold a candle next to pharmacy benefit management. Pharmacy benefits are like a riddle wrapped in a mystery inside an enigma, okay? They're extremely complex, but it's also an area of tremendous opportunity for employers that are willing to innovate. Transparent and independent pharmacy benefits is a cornerstone of a high performance plan. Here you see an overview of a pharmacy analysis that we conducted for a very large public employer in Florida last year. Here you can see on the left, I don't have it highlighted, but on the left, you can see the number and volume of brand and generic dispensations in a year that they had. The overall total claim spend just on pharmacy was a little over $6.8 million, okay? Now that was gross spend, and it didn't include any rebates that the employer got back from the PBM, but neither did our alternative recommendation, which we're going to show you in just a second. Now this employer was also adamant that they were receiving 100% of their rebates back from the PBM. And we did discover a little bit later on that that was true. Technically, it was true. We're gonna discuss a little bit more of that on the next slide. But I want you guys to look at this center column here, this column F. Take a look. What we also found here in our analysis is that this PBM was making an undisclosed $947,000 on generic spread pricing. Generic spread is the difference between what the PBM purchases the generic meds from the manufacturer for versus what they turn around and sell the employer the same generic medications. It's almost $1 million just on generic spread. There was over an additional $574,000 of savings opportunity on brand medications. You see that there. So by switching to a fully transparent and fully pass-through PBM, this employer will be able to immediately reduce their pharmacy claims alone by more than $1.5 million a year with virtually no disruption to the employees whatsoever. Now, once again, the issue here that's in play here is transparency. Employers just don't get to see this information. Remember when I said that the employer insisted they were getting 100% of their pharmacy rebates? Here's why. Right here in this short little sentence right here, it says right here that the rebates, 100% of the rebates go back to this city, okay? It was a city. But here's the first point. Formulary rebates are only one form of rebate, and there are actually other forms of rebates out there. And guess who gets to define what a rebate even is in the first place? That's right. The PBM gets to define what a rebate even is. But here's what I really want you to see right here. We found this buried deep in the PBM contract language, and it says Florida Blue, that's who it was, Blue Cross Blue Shield of Florida, may receive a portion of the rebates on a prepaid estimated basis before any drug claims are filed and paid. To the extent that they receive a prepaid estimated rebate, Florida Blue retains as part of its compensation the interest earned on such amounts from the time it receives the payment until it gives it the rebate back to the employer. So in other words, Prime, who was the PBM, was paying Florida Blue prepaid rebates on prescription medications even before they were dispensed. Then they were investing those rebate dollars, earning interest on it for a period of 9 to 12 months, and then they kept the interest, okay? Now guys, our stance and the Health Rosetta stance is this, that all manufacturer generated revenue belongs to you, the employer, including rebates and interest, clawbacks and fees, doesn't matter. All of that revenue is generated off of your plan assets, and it belongs to you and your employees. So Health Rosetta plans eliminate contract language like this, and we utilize philosophically aligned PBMs that are willing to put in writing that 100% of all manufacturer revenue, not just rebates, flow back to the employer and the plan and the employees, as it should. High performance plan design, documents, and risk management. So one of the biggest success stories for high performance Health Rosetta modeled health plans comes from the state of Montana. Okay, some of you may know or have heard of Marilyn Bartlett. Marilyn's a friend of mine, and she's also a Health Rosetta collaborator and contributor. Well, back in 2014, Marilyn worked for the state of Montana's health plan, which covered more than 30,000 employees and their families. The health plan was going broke, with losses expected to exceed $50 million in just a few years. So I'm going to cut this story a little bit short because I know we're running close to the time here. Long story short, in just a short amount of time, 3 years as a matter of fact, she was able to turn the plan around. She fired the state's PBM. They implemented a transparent PBM. They hired an independent TPA. They implemented much of the solutions that we've been talking about. And she turned a potential $50 million deficit into a $30 million surplus in just 3 years, okay? And for her accomplishments, you can see that here, Fortune magazine named her one of the world's 50 greatest leaders. Now, since then, Marilyn's moved on, and now she's working with an organization that's working with state health plans all across the country, okay? So if you are interested in her story, just reach out to me. Happy to share more about Marilyn. So what we've been describing is unbundling your plans a little bit. And when you unbundle the health plan and build it back with high performance components and vendors, it creates enormous potential for savings and quality improvements. But I'm gonna be honest with you, it does require a whole lot more oversight and management. So without proper support and guidance, plans can turn out looking like Mr. Potato Head here on the left. Look at this guy. I mean, he's got all the right parts. They're just not in the right place, or they're not working like they're supposed to, or they're not yielding the results that you expect. The Health Rosetta has simplified this process for employers, opening an enormous and ever-evolving world of new strategies, tactics, and vendors. Plans like this right here. I want to give you a plan example. This employer right here transitioned away from United Healthcare and custom designed these two plans you see here on the right. Now, under normal circumstances, you'd probably say that this employer was paying through the nose. Instead, their costs went down. So for far too long, employers have believed that the only way to reduce healthcare costs is to slash benefits or shift costs to employees. And Health Rosetta plans are proof that doesn't have to be the case. It is possible to reduce your costs and improve your benefits simultaneously. So as I wrap up today, I'm going to leave you with 5 action steps you can take right away. Number 1, reset your benefits advisor relationship expectations. Working with transparent brokers and consultants that have deep expertise and a tremendous commitment to aligning their interest with your interests is very, very important. The bottom line here is you need skilled and knowledgeable people that are fully aligned with your company's interests. Number 2, start now and select approaches that minimize disruption to your group. Many of the solutions that we support and promote and implement, you don't have to wait until open enrollment time. Okay, you can do those things starting right away. Build compounding momentum by implementing programs that quickly reduce spending and deliver value, like doing a pharmacy analysis or doing an analysis on out-of-network claims repricing. All of these things are things you can do right away to get some immediate ROI. Develop an outstanding communications strategy. That kind of goes without saying. All change management requires a very strong communication strategy with your employees, and the Health Rosetta can help. And then last but not least, let the Rosetta help guide the way, okay? The Health Rosetta is about giving employees access to resources, insight, and experts to navigate this process we've been discussing. Now, we've only scratched the surface of what Health Rosetta is, okay? But our status quo healthcare system is overwhelming us, making too many of us lose hope. And if I only accomplish one thing in today's presentation, it would be to create hope in the simple, practical, proven fixes that we've discussed today. Hundreds of thousands of regular citizens, clinicians, CEOs, HR professionals are restoring the American dream, one community and one company at a time. They're stepping up in grassroots groups and working together to solve the biggest challenges in healthcare. That is what America does, hands down. We're the best at solving problems from the bottom up. Health Rosetta's mission is to simplify recreating these successes in our own organizations and companies and in our own communities all across America. Healthcare is already fixed. Join us to scale those fixes. Thank you guys so much. So if you'd like to learn more about the Health Rosetta, I posted some information here, some contact information for us and Health Rosetta directly. And thank you again, PHRA, for this opportunity to introduce everyone to Health Rosetta. We're gonna, have a few minutes. I know we're a few minutes over, so if you gotta go, completely understand. But if anybody has any questions, I'll stay on for a couple of extra minutes or use the Q&A down there next to the chat feature, and I'd be happy to answer any questions. If not, you guys stay warm. Thank you for attending, and have a great weekend.